Hello friends, today we will discuss ultrasound guided femoral nerve block at femoral crease. Objectives of my presentation are to discuss relevant anatomy of the femoral nerve, to do preoperative assessment and preparation of the patient, indication and contraindication of femoral nerve block, complication and side effect of femoral nerve block, prerequisite of femoral nerve block, equipment and logistic required, ultrasound setting. We will discuss sonoanatomy of femoral nerve. We will discuss how to make position for femoral nerve block. We will discuss conduct of femoral nerve block, intraoperative care, postoperative care, and clinical tips. Relevant anatomy of femoral nerve. The femoral nerve is the largest branch of lumbar plexus, arising from ventral rami of nerve root, lumbar second, third, and fourth. Femoral nerve emerges lateral to the psoas muscle and descends to pass beneath the inguinal ligament at approximately its mid position. Before entering in thigh, femoral nerve innervates iliacus and pectineus muscle above the inguinal ligament. After entering the thigh, femoral nerve splits into anterior and posterior branches at femoral crease or inguinal crease. Femoral nerve passes through the femoral triangle, lateral to the femoral artery and vein. Vein is most medial, then there is femoral artery, and the nerve is most lateral. Femoral nerve lies outside the femoral sheath and it is invested in two layers of fascia iliaca and lies on iliopsoas muscle. This is a diagram showing femoral nerve relationship at inguinal ligament. On the topmost region you can see the inguinal ligament and below this is iliacus muscle. You can see the femoral nerve is invested in two layers of fascia iliaca. Medial to it are femoral sheath which contains femoral ring, femoral vein and femoral artery. Most medial is pectineus muscle which is supplied by the femoral nerve. Both muscles iliacus and pectineus are supplied by the femoral nerve in the pelvis. This is a diagram showing formation of the femoral nerve in the lumbar region. You can see lumbar 2, 3, 4 nerves. They pass in the mass of the psoas muscle, and this diagram from one side, psoas muscle is removed. 3 nerves make femoral nerve and pass under the inguinal ligament. Femoral nerve divides in anterior and posterior branches after entering the femoral triangle. The anterior branch supplies only one muscle, sartorius muscle, and divides in medial femoral cutaneous branch and lateral femoral cutaneous nerve, which supplies anterior and medial portion of the thigh. The lateral portion is supplied by the lateral femoral cutaneous nerve. The posterior branch supplies the hip joint, gives 4 motor branches to 4 parts of quadriceps muscle and a tweak to knee joint, and continue as saphenous vein. So it supplies one muscle which has 4 parts, and it supplies the upper joint which is hip and the lower joint which is knee. The saphenous nerve moves in the adductor canal and provides sensory innervation to the medial leg up to the toe. We will discuss saphenous nerve block in the next video. This presentation is restricted to femoral nerve trunk block. If we summarize the branches of femoral nerve, in the pelvis or before entering the femoral triangle, it supplies nerve to iliacus and nerve to pectineus. The anterior branch supplies one muscle, which is sartorius, and 2 cutaneous branches, medial cutaneous nerve and intermediate cutaneous nerve. Branches from posterior division are 4 branches to quadriceps femoris and then continue down as saphenous nerve. It also supplies hip joint and knee joint. Dermatomal innervation of the femoral nerve. There are total 4 cutaneous nerve which comes out from femoral nerve. First is the intermediate femoral cutaneous nerve carrying sensation from anterior and middle of the thigh. Second is medial femoral cutaneous nerve carrying sensation from anterior and medial aspect of the thigh. Infrapatellar branch, saphenous nerve supplying innervation of infrapatellar region, which is a small branch. The fourth branch is saphenous nerve itself carrying sensation from medial surface of tibia up to the base of the big toe. This is a diagram showing the sensory innervation of skin, in which you can see the green is intermediate femoral cutaneous nerve, pink is medial femoral cutaneous nerve, which supplies medial of the thigh, and the intermediate supplies intermediate portion of the thigh. The lateral portion is supplied by lateral femoral cutaneous nerve. In light blue we can see infrapatellar branch of the saphenous nerve, which supplies small portion near the knee. The fourth nerve, cutaneous nerve, is depicted in blue, which is saphenous nerve, which supplies medial side of the tibia up to the big toe. This is the total supply of the femoral nerve and lower limb. Regarding dermatome, as we discussed earlier, it supplies medial portion and anterior portion, some portion at the knee and in the leg, medial side of the tibia up to the big toe. The myotomes are muscles supplied by femoral nerve, iliacus and pectineus in the pelvis. It supplies sartorius muscle and core part of the quadratus femoris muscle. Sclerotome or orthotome supplied by femoral nerve. We can see here anterior portion of the hip joint, femur, anterior portion, lateral portion throughout, patella and some portion of the tibial head up to the tibial tuberosity. Preoperative assessment and preparation. Our preoperative assessment and preparation include routine preparation, that is taking history, doing physical and general examination. We do lab investigation. We do risk assessment and grading, and we optimize the comorbids and preparation of the patient. We take consent, we make the patient NPO, and we do side marking. Indication of femoral nerve block include surgery on lower leg and foot in combination with sciatic block. Surgery on leg and foot can be blocked safely with combination of femoral nerve and sciatic nerve. Saphenous vein stripping can be performed safely for intraoperative analgesia under GA or as a sole technique with the femoral nerve block. Surgery on anterior thigh can be performed. Surgery on medial side of the leg can be performed. The medial side of tibia is supplied by the femoral nerve, and medial surface skin is also supplied by the femoral nerve. Surgery on knee needs analgesia, in which femoral block helps. We can use femoral block because 4-5 nerves of the knee joint are supplied by the femoral nerve, and sciatic also gives branches from the common peroneal and tibial nerve supply to the joint. One branch also comes from the obturator nerve, but most of the nerve supply is from femoral, so it works well. Analgesia for fracture neck femur can be provided by femoral nerve block. Contraindication of block include patient refusal and non-cooperative patient, local sepsis and infection at the site of injection, allergy to drug, and if there is neuropathy. Complication and side effect of femoral nerve block include sometimes the block is partial or failed because we do not recognize or identify the fascia iliaca sheath, and we deposit the solution out of the fascia iliaca, which can cause partial or failed block. Infection can occur, which needs sterile technique. Intraneural injection can occur, which can cause nerve damage. Nerve injury includes neuropyrexia and neurolysis. Intravascular injection, there are high chances in this block. In this situation, either the drug is lost in the vein or artery and we don't see the spread of drug under ultrasound. In second situation, drug can go into vein and cause local anesthetic systemic toxicity. Bleeding and bruising at the puncture site can occur. It can go into iliacus muscle and it can cause intramuscular hematoma. Allergic reaction to local anesthetic can occur. Reflex sympathetic dystrophy can occur when we irritate the drug or puncture the femoral nerve. Prerequisite of ultrasound guided femoral nerve block. This block needs sterile technique, bright light source, intravenous access with 18 gauge working cannula. We apply standard monitoring equipment. All resuscitation drug, including lipid solution, should be available to manage toxicity, which is rare but can occur. Our assistant must be trained and he knows the art of regional block. GA facilities must be in hand. If the block fails, consent must be taken and all details must be briefed to the patient. NPO must be confirmed and signed and done. Equipments required. Ultrasound machine with a high frequency linear array transducer is required. We use 14 to 16 megahertz ultrasound probe with exam type nerve. We need ultrasound probe cover, which should be sterile. We need ultrasound gel. Needles are insulated, blunt bevel, ecogenic, and the length of needle should be 50 millimeter. We need sterile gloves, sterile cleansing solution. We need sterile towel to isolate the area. We need 5 cc syringes with local anesthetic for puncture site analgesia. We need pressure measuring syringes with tubing to detect intraneural placement, which shows higher pressure in the syringe, and an indicator showing high pressure. Usually we need sedatives, analgesics, midazolam, fentanyl and ketamine. We use conscious sedation or pseudoanalgesia. Normally I practice analgesia sedation after testing the block. There should be facilities available to convert to general anesthesia if required. Ultrasound setting. We put ultrasound machine in front of our eyes. We use high frequency linear probe with frequency more than 14 megahertz. We use in plane technique. Out of plane technique can be used. We identify orientation of needle with the probe. We keep the angle of needle with probe at least less than 30 degree for better visualization. We can manipulate pressure to decrease angle, and this is described in the next slide, how we apply pressure on the one side to have better angle and better visualization. Best views obtained when needle is parallel to the probe. Required needle length is 50 millimeter in an average person. Depth setting required is 1 to 3 centimeters in 70 kg person. This is a diagram showing angle of the needle and probe manipulation. You can see if the angle is 65, we will not see any needle in ultrasound image. But by a small manipulation of pressure on one side of the probe angle, we can bring the needle in our view. Making position for femoral nerve block. Block is executed in an area designated especially for regional block. All facilities of general anesthesia must be available in this area. All facilities must be available to deal with local anesthetic systemic toxicity. We elevate the bed up to avoid bending of the operator. We keep the patient in supine position. Ultrasound machine is kept on opposite side in front of the operator. We place transducer at inguinal crease parallel to the inguinal ligament. Inguinal crease or femoral crease is a obviously visible structure. The operator will work from same side of the patient. We keep the routine pillow support to relax neck muscle of the patient. This is a diagram showing position and conduct of the femoral block. The operator is standing from the same side of the leg to be operated. Sonoanatomy of the femoral block. Sonoanatomy is essential before practical conduct of the block, and this should be a routine practice in every block to assess the block. There is a high variation in normal anatomy of the nerve in every block. The femoral nerve can be blocked at different levels and it needs different sonoanatomy. The first point is fascia-iliac block, which is discussed in separate video. The second point in which femoral nerve is blocked is at inguinal crease. It will be discussed in this video. And the third block is subsartorial block or adductor canal block. It will be discussed in separate video. Below knee block, one of the most easiest block to be performed, which is below the tibial tuberosity. It is subcutaneous infiltration for the saphenous nerve block. The fifth point where femoral nerve block is done is at the medial malleolus. It is the part of the ankle block, which will be discussed in a separate video. The preference of the block depends on the area of innervation. So different block has different indications that will be discussed in different videos. This is a diagram showing sonoanatomy of the femoral nerve. We can see the skin above all and subcutaneous tissue, and then there is fascia lata. It's a blue color, light blue color, which is the socks-like structure covering whole thigh. And then we can see the femoral nerve, femoral artery, and femoral vein. Femoral vein is the most medial structure, and femoral artery is in between. Most lateral is femoral nerve. You can see in this video, fascia lata passes above all three structures. While femoral nerve is invested in the two layers of fascia iliaca, which are part of the iliacus muscle, and totally separate structure from the femoral sheath. Femoral nerve is not the part of femoral sheath. Conduct of the block. Sonoanatomy is done before preparing and draping the block area. Sign-in and site marking is done in pre-op holding area. Sterile preparation of the area done and area isolated with towels. We use puncture site analgesia. Femoral trunk is blocked when the patient are not expected to be mobile after surgery. That is when we don't need a motor sparing block. If we need a motor sparing block, we have to come down to avoid the nerves which are given from the femoral nerve at femoral crease. We do subsartorial or adductor block for them when we need the patient to be mobile. First we feel femoral artery by palpation, and we put probe over the femoral artery in femoral crease parallel to the inguinal ligament. We identify femoral artery on ultrasound image, and femoral vein lies medial to it, and the femoral vein is a compressible structure on applying pressure. Femoral nerve lies lateral to the artery, hyperechoic structure. Iliacus muscle lies below the femoral nerve, artery and vein. Femoral nerve is invested in two layers of fascia iliaca. Outer layer passes above the femoral nerve and below the femoral artery. Fascia lata passes above the femoral nerve, artery and vein. Fascia lata is a fascia which covers the whole thigh like a socks. Medial edge of sartorius muscle may be visible lateral to the femoral nerve. The advancing needle for the block may pass through the sartorius muscle to reach the femoral nerve. We use in-plane technique to reach between two layers of the fascia iliaca near lateral part of the femoral nerve. Our needle is never directed to the nerve itself, but to the most lateral part of the nerve to reach between the two layers of the fascia iliaca. We use part, see the next slide, to optimize best view of the femoral nerve. We can see the femoral nerve in best view with a caudal tilt of the probe. Femoral crease is the area where femoral nerve gives its branches and femoral artery gives its branch profunda femoris. If we find two arteries on the ultrasound image when we put the probe on the femoral crease, then we have to move cephalate to block main trunks of the femoral nerve. When we inject local anesthetic in between two layers of the fascia iliaca, fluid pushes away femoral nerve away from the needle tip and encircles femoral nerve. To avoid intravascular injection, we aspirate every time we inject. To avoid intraneural injection, first check when we inject the drug, patient should not cry, should not complain of pain. Pain on injection is a indication, is a sign that we are injecting in the nerve trunk. Second, when there is high pressure to the injection, we have to stop. The third is we use nerve stimulator at lowest current of 0.1 milliamperes. When we are intraneural 0.1 milliampere, it gives muscle twitch. When we inject local anesthetic under direct vision, we can see the fluid passing through the tip of the needle. Last is we use interfacial plane to avoid direct contact of needle with the femoral nerve. This is a diagram showing manipulation of part, PART. We can move according to need. P means pressure, alignment, rotate and tilt the probe when required. And we also use cephalic tilt for the femoral trunk block in this block. Intraoperative care. We brief all details of the block to the patient before starting the procedure in the preoperative visit or in the morning of surgery in the preoperative holding area. We apply full standard monitoring as for GA throughout the procedure. We avoid hypothermia. We use full body bear hugger. We test motor and sensory block before tourniquet or incision. We isolate the limb by full screen. Pseudoanalgesia can be given but better after confirmation of the block. Pseudoanalgesia can mask signs of the local anesthetic systemic toxicity. We monitor the local anesthetic systemic toxicity and we keep in hand lipid emulsion in OR and also in recovery. Alternatively, close verbal communication is maintained with the patient if sedation is not given. In case of inadequate block, get ready to convert the patient into general anesthesia. Post-operative care. After finishing the surgery, we shift the patient gently to the recovery area. Same way we apply the monitors, standard monitors. We monitor the patient for local anesthetic systemic toxicity. We inform the patient about approximate time of return of sensation, so he should not worry and feel the sensation of handicapness. We exchange cell phone contacts to assist in case of problem or queries, and the patient can talk to the anesthetist whenever he wants. And I recommend this and I always do like this. Early mobility can be done with femoral nerve block. Early resumption of food and drink can be done with femoral nerve block, sole nerve block. Early pain-free physiotherapy if required can be done. We prescribe analgesia IV or oral when block wears off. Clinical tips. We put ultrasound machine in front of the eyes to comfort the neck of the operator. Easy movement. Sonotomy is must before practical conduct. We always give support to the probe hand and needle hand to stabilize the view. We use sterile technique always. We confirm orientation of needle with ultrasound probe. In-plane technique is usually used. Out of plane can be done. Color Doppler should be used to avoid femoral vein puncture. Optimal volume is 15 to 20 ml. Low or higher volume may be used. We inject local anesthetic in small increments and encircle nerve like donut. We don't move needle until full needle is visible with the bevel cut. To avoid intraneural injection, we observe if there is pain on injection, we stop giving the local anesthetic. And we check pressure in the tubing. It should not be more than 15 psi. And an indicator is there if the pressure goes high. To avoid intraneural injection, we check the fluid passing through the tip of needle, and if it is not passing, means it is in a vessel. We use interfacial plane. That means we don't direct the needle towards the center of the nerve, and in this block we direct the needle towards the lateral most part of the nerve. Our target is to reach in the interfacial plane, and this is 2 layers of the fascia iliaca, and open the space, and then we inject the local anesthetic solution. We use nerve stimulator at the lowest current of 0.1 milliamperes, and if we are intraneural, it will give a twitch. Thanks.